Good morning. It's my pleasure to be here today. A terrific talk by Dr. Pochapin. So I'm going to talk today about some of the work we're doing here at NYU, focused on community-based approaches to improving colorectal cancer screening. So when we think about health inequities, we often think about how hypertension is more prevalent in African Americans and kills more African Americans than any other group. But many people don't think about colon cancer as a health inequity. But we can see that that many more black men die from colon cancer than do other groups. Part of the reason for that is nationally, black men are less likely to get screened in a timely fashion, either by stool-based test or by endoscopy. New York City, however, has been very successful at closing the gap between blacks and other groups. And here's the pointer. And what we see is from 2003 to 2010, the gap between white, black, Hispanic, and Asian has basically closed, where we're seeing that basically all groups in New York City are getting screened at the same rate. Unfortunately, we still see a disparity in terms of death from colon cancer, where blacks are more likely to die, unfortunately, than whites, Hispanics, and Asians. Why do we see this difference? Well, as we mentioned, black men are less likely to have screening colonoscopy before the age of 65. So Dr. Pochapin mentioned the importance of getting screened early, and that's not only so that we can detect polyps, but also if there's cancer there, so that we can detect it at a very early stage, because we're much more likely to cure it. There's also some evidence that suggests that blacks are less likely to have diagnostic colonoscopy after an abnormal screening test. And there's actually some work going on in New York City looking at the actual biology of the cancers. And there's some evidence that the cancers in blacks might actually be more aggressive. Well, one thing that we know for sure is that black men are also less likely to have a primary care doctor. And we know that referral to get a colon cancer screening procedure typically happens from the primary care doctor's office. But unfortunately, black men, for a number of reasons, are less likely to visit primary care doctors. So what can we do to reach black men, this group that's at the highest risk of dying from colon cancer? Well, we thought about reaching out to community-based venues, including the church and the barbershop. These are places where we're more likely to find black men than in primary care doctors' offices. The barbershop is a place that I started working in about 5 years ago in Dallas, Texas, where we found that on average, black men visited their barbers about once a month, and they had been with the same barber for 7 to 8 years. I don't know many doctors who have that kind of track record. But in churches, we found, we also thought that that was a great place to try to reach black men. One, because there's a church in just about every neighborhood. Churches are a trusted non-medical setting. And in urban black communities, 65 to 80% attend church regularly, and half of older black men attend church at least once a month, similar to barbershops. And when you look at larger congregations, black men comprise about 35% of those congregants. So we think that these community-based settings are great places to partner with to try to do community outreach for colon cancer screening. So we actually have a couple of studies. This is an example of one. It's the faith-based approaches in the treatment of hypertension and colon cancer prevention. And we're recruiting men from churches through a community outreach program, and we're enrolling them into our study where we're looking at ways to improve high blood pressure and ways to improve colon cancer screening. And once we enroll men into our study, we basically follow them for about 6 months, and we do something called culturally tailored patient navigation, where we basically try to grab the men by the hand and walk them through the process, which can sometimes be complicated, of getting a colonoscopy or a stool-based test. And at the end of 6 months, we see how successful our intervention was. So this complicated slide basically summarizes all of the projects that we have going on focused on improving colon cancer screening in Black men. So it's the NYU Comparative Effectiveness Research Program. We have a church-based study, and we have a barbershop-based study. And we basically recruit men from churches and barbershops, and we enroll them into our study, as I mentioned. And they get randomly assigned either to a blood pressure intervention or to a colon cancer intervention, which I described, where there are actually community health workers who are working with the men for 6 months to try to get them to get screened for colon cancer. And we evaluate everybody at 6 months to see whether or not we were able to get them a colonoscopy or to complete a stool-based test. So far for our program, we have screened nearly 6,000 men for our study, and we've enrolled over 1,000 men for our study. And we've worked with about 79 barbershops, 70 churches, 7 mosques, and a range of other settings, including transitional housing, social service organizations, several health fairs, and festivals for over 200 sites in the last 2 years. This is just a map that shows many of the sites where we are, but as you can see, we're basically in all 5 boroughs of New York City. So what do we do when we go to these churches? Well, every couple of months we actually go out and we canvass for churches, and we actually make contact at a church, and then we find a contact person and try to engage them, let them know what we're doing and about the importance of focusing on improving colon cancer screening in Black men. Then what we do is we actually identify someone at the church who will work as a lay health educator. So this is someone that we train for several hours, and they actually help us to educate their church members about colon cancer and what they can do to prevent it. We then have a screening event at our at the church, where we actually do an educational program similar to this at the church, and we actually try to enroll them into our study. And for those who are not interested in our study, we still refer them to where they can get a colonoscopy. And here in New York City, with the incredible Health and Hospitals Corporation, where you can be seen for what you can afford, there are ways to get screened in New York City, even for people who don't have health in insurance coverage. So once people are enrolled into our study, they work with a community health worker who works with the lay health educator. And over the next 6 months, they actually get several telephone calls to try to address any concerns or barriers they have about getting screened for colon cancer. And those barriers can range from getting the prep, from identifying where they can actually get a colonoscopy, for what they can afford, trying to identify an escort. So we try to identify whatever the barrier is, and we try to address it over that 6-month period. And then we see at the end of 6 months whether or not we were able to get that person screened. Some of the challenges that we have come across, many of the participants don't know about colon cancer and the risk of colon cancer and the importance of getting screened, and the fact that colon cancer is one of the most preventable cancers that we have. Many of the participants have a lack of urgency, health insurance issues, but then we also find other social issues like housing and phone issues, and we try to address those, what we call non-medical issues, to the best of our ability. We found some incredible lay health educators at these churches, And the ones who are dedicated and who are very comfortable talking about health information, we find are the most successful at helping to get their congregation screened. So we have found that the population that we're dealing with is slightly different from the New York City population. In general, the men that we have encountered are a little bit less educated and also less likely to be screened. So we think that our program is very well placed because Black men are at the highest risk of dying, but yet it looks like they're getting screened least in New York City among our group of men. So just wanted to give you a small sampling of some of the things that we are doing. Our study continues. It goes on for the next 2 to 3 years. We ultimately hope to enroll 1,400 men in our program to see if this very intensive kind of counseling and follow-up helps to increase colon cancer screening and hopefully will continue to close the mortality gap. So I'd like to acknowledge the incredible church and community leaders for their hospitality. They've been incredibly welcoming, and I'd also like to thank our incredible research staff who is incredibly dedicated, and our funding sources from the NIH and CDC. It's been my pleasure to be a part of this project, and I'll turn it back over to Mark.